So today I want to talk about subclinical hypothyroidism / euthyroid 6 syndrome. When I was training, we generally called it euthyroid 6 syndrome, and I think now it is more, it might be referred to as subclinical hypothyroidism. And I want to, I want to portray to you that I believe that this is a much more common illness than what we as physicians recognize. And I'll go through some of the clinical findings and then show you some patients and then give you some examples of why I'm thinking that way. So there are no conflicts, and the goals for this will be to define what is subclinical hypothyroidism, euthyroid 6 syndrome, and then review thyroid function in general, and then go through some treatment and then offer some cases. So subclinical hypothyroid, euthyroid 6 syndrome. So if you read the literature, they talk about it being known as non-thyroidal illness syndrome, or NTI. So it's described as abnormal findings on thyroid function tests that occur in the setting of a non-thyroidal illness. In other words, it's not involving the pituitary gland or the thyroid gland or the hypothalamus. This is more of a general physical illness of the person's body. Okay? This is critical though. After recovery from NTI, a non-thyroidal illness, these thyroid function tests should become normal again. Okay? So this is more like the things they're describing are people that would be in an intensive care unit and have fallen dramatically ill, and now all of a sudden their thyroid functions are very skewed. Once they get out of the intensive care unit, though, you would expect that their thyroid functions would come back to normal. So that's the idea here. So we're talking about a severe illness, okay? So now, what they describe it as is multiple alterations in serum thyroid functions have been recognized in patients with NTI without pre-existing thyroid problems. And the most prominent alterations are low serum T3, triiodothyronine, and an elevated reverse T3, okay, leading them to term this as low T3 syndrome. The other hormones may not be bothered, may not be affected. TSH, thyroxine, free T4, they are affected in varying degrees. But again, the idea is that after severity of the illness, these T3 and T4 levels will gradually normalize. Okay? So we're talking about a low serum T3 and a low reverse T3. All right? And I'll explain, if I didn't know what a reverse T3 was until several years ago, and so I'll explain what those are. This comes from Medscape. So this is kind of a chart of what it would look like. You have you have mild, moderate, severe, and then recovery. So this is over time where a patient becomes ill, and reverse T3 goes up, and the active T3 goes down, and over time you'll see that the T4 and the TSH will fluctuate, but the idea is that over time there's a recovery phase and they'll normalize. That's the kind of concept of euthyroid 6 syndrome. So let's go on, hold that in your mind, and we're going to talk about thyroid. So remember, thyroid is a clinical diagnosis. It's not just laboratory diagnosis. So generally the patients don't feel well. They'll tell you that I feel out of balance. I feel like my hormones are out of balance. They don't feel like themselves. Something's happened. They don't feel energetic. They can't think right. They have brain fog. They just don't feel like they used to feel. Fatigue is a big factor. Lack of concentration. And then the classic like dry skin, constipation. They may feel depressed because they're just slowing down. Their whole body, the thyroid hormone responsible for metabolism, is slowing down. So remember that these are the clinical factors that you diagnose also for thyroid. And then it's also a laboratory diagnosis. And I like to use the free T3, the free T4, the TSH, and the reverse T3. And I like to use the free versions because, remember, thyroid is bound to thyroglobulin No, it's bound to thyroid transport hormone, and it's the free aspect of the thyroid that is actually active and interacts with the cells. So that's what we want to know, is how high is our free? Is it high enough to do something? So we look at the free levels. So what's a clinical picture of euthyroid 6 syndrome? So think of this as, this is a person that's severely ill. They're fatigued, they're tired, they're not their normal energy level, they have brain fog, and they can't concentrate. Now, of course, someone in an ICU or an intensive situation is going to have that. But what I think is happening is that not just, euthyroid 6 syndrome is not just an acute episode, it happens in a chronic episode. So these are patients that are chronically significantly ill. So they are what we call the chronic illness patients, like they have autoimmune disease, they have anxiety, they have depression, they are not digesting well, and now they become they have chronic medical issues, and that starts to disrupt the thyroid whole mechanisms in the same way that euthyroid 6 syndrome does in an acute setting. However, remember,
I would just put the X-Men top right there.
Remember, in that acute setting, it's expected that the thyroid hormones are going to normalize. But I think that what happens is in the chronic setting, these thyroid hormones never get a chance to normalize because the patient never gets better. They stay chronically ill, they stay chronically depressed, anxious, they're not sleeping, they're insomniacs, and they just never ever get out of this dip that they're in. And then they come into you and they're saying, I'm exhausted, I'm burned out, but they're still functioning to some extent. They're still working, they're still able to do their jobs, they're living with their families, but they're still at a very low level of functioning. They're, what is wrong with me? This isn't how I usually am. Okay, so there we go. So let's look at some lab results of a euthyroid 6 syndrome. So this is a lady that sorry, it's a little blurry, but she's 48 years old. She's 48 right there. She's had a gastric bypass about 8 years before. So what do gastric bypasses do? Basically, they starve the body into weight loss. They literally starve the body. They lack nutrients, they can't absorb them, and now all of a sudden, after about so many years, they start to deplete their inner stores, and now they are basically starved. So she comes in, she has fatigue, she has insomnia, and she has anxiety. You know, that's like 75% of the population walking around now. Chronic illnesses, okay? So you look at her thyroid functions, and right here I circled it. That is her free T3. The range goes from 2 to 4.4, and she's at 2.1, all right? But if you look at her free T4, she's at 1.05. That's sort of a normal range, or a normal level there. And her TSH would be 3.74. If you just ran a TSH on her, you'd tell her nothing's wrong with you. But she's got a free T3 that's almost below the laboratory range, which is very low, all right? Other aspects of this lab work is if you look down in this little area down here, you can see that her adrenal glands, her DHEA is only 23. She barely is making any adrenal hormones. This is what happens: chronic fatigue, gastric bypass, chronic malnourishment. So this is a classic picture. If this person were in the ICU, you'd say, wow, she's got euthyroid 6 syndrome. Look at her free T3. It's totally down. The T4 and TSH are in a normal range. But she's been chronically in this state now. The next one is another one that is 70-year-old female, chronic pain. She's had surgeries. She's on pain medicines. It's just chronic conditions. She's on a number of pain medicines. Comes in feeling fatigued, run down, all the classic symptoms. So I did blood work on her. And if you look at her, she's got, really interestingly, I think she was on Synthroid. but her TSH is 0.14. So you would say, wait a minute, if her TSH is low, maybe she's got high thyroid. Her free T4 was 1.85. 1.85. That's above the normal range. That's a high thyroid. But if you look at her T3, it's down to 2.1. So there's a problem here. This is a lady that's got plenty of T4, but she's not making any T3. The T3 is the active hormone. The T3 is the one that runs around the body and does the work. So this is another example of a euthyroid 6 syndrome, where this lady has got plenty of plenty of T4 and TSH, but now her T3 is very low. And if you look at her reverse T3 right here, 26. That should typically be 10 to 12. She's double what she should be on the reverse T3. High reverse T3, very low T3. That's the active hormone. I'll go into the hormones in a little bit. But now you're getting this picture of what the euthyroid 6 syndrome is. So the next one is a really nice gentleman from New York. He's 65 years old, came out here to be with his daughter. He was a sanitation worker in New York and just got beat up. He had herniated lumbar discs, he had neck discs. He was on 300 milligrams of morphine before he saw some pain specialists in El Cajon. They started reducing his morphine level, which he's not dealing with too well, but basically chronic pain, insomnia, anxiety, depression, all the above. So this gentleman comes in and he says, I don't feel well. So I said, let's get the blood work and see where you're at. So again, if you look at this, his TSH is 2.86. If you run a TSH alone, you say, well, that's normal. His T4 was 0.99, not bad, but his free T3 was 2.2. Remember, 2.0 is the laboratory cutoff, which is extremely low, and this guy is almost below that. Again, his reverse T3, 16. So we have a low free T3 and a very high reverse T3. And that's important because I'll explain what the reverse T3 is. This man is also on testosterone because he blew out his male hormone system. And if you look at his DHEA, it's only 16. That's an adrenal hormone. That should be above 100, 150. If you look at his pregnenolone down here, another adrenal hormone, that's like the master adrenal hormone. It's at the top of the pyramid. They can't even detect it in this man. It's so low. It's undetectable. So we're talking about a gentleman who's burned out all three of the major hormone systems. He's no testosterone. He's on testosterone replacement. His thyroid is low, and now his adrenals are not functioning well. So yeah, he doesn't feel well.
Joe?
Yes?
In that case, would you ever see somebody who's already on testosterone replacement? Would that tend to decrease the pregnenolone?
I haven't seen that. Okay. I didn't have his blood work before he was on testosterone replacement. He was on that from another clinic.
I was just curious.
But in the past, when I'm doing it on the different patients, I don't see that happening.
Okay.
So those systems in males don't cross. In females, you will have the DHEA crossover and become testosterone. Okay. So again, chronic pain, fatigue, low testosterone, depression, anxiety. Now the last patient that so that's the three patients there. Just to give you an idea of, I don't think euthyroid 6 syndrome is just in the intensive care units. I think it's pervasive in our population. So, okay, let's look at thyroid hormones. Where does thyroid come from? So, we start at the top. Thyroid comes from the originating amino acid. This is critical. It's an amino acid. Is phenylalanine. Phenylalanine becomes tyrosine, and then the tyrosine becomes it's iodinated, and then it becomes T4, which is 4 iodines. That's the T4. Then what happens is the T4 is then deiodinated to T3. So that's a process. Now the T4 is what I call storage hormone, and the T3 is the active hormone. So these people have got a defect in their ability to convert T4 into T3. We have plenty of T4 floating around, but they have very low T3s. And on top of that, they're converting the T4 into reverse T3. And the reverse T3 is inactive. It's a very inactive molecule. It's isomers. It's a right hand and left hand. The active T3 and the reverse T3 are isomers. One is very active and one's not active. And one is the one that turns on the cells, the active T3, and the reverse T3 actually can sit on the receptors and block the real T3 from doing its job. So therefore, it's already inactive, but then it stalls the ability of the thyroid to do its job. So now, okay, this is key. Phenylalanine is an essential amino acid. So to even start this system up, you need an essential amino acid. Remember, essential amino acids are the ones that we don't manufacture within. We have to eat them. We have to take them in. That's protein. Amino acids come from protein. So if people aren't eating protein, they're not getting their amino acids and they're having difficulty building up their thyroid functions unless their body starts stealing from other proteins within the body. So if your patient's going to Circle K and getting a big gulp and a donut in the morning and then a Red Bull in the afternoon with a bag of chips and 3 beers at night, they're not taking any protein in and they're not making any they don't have any amino acids to start this whole cascade. And that's what a lot of patients do. So remember, tyrosine is required. It's an amino acid and you need to eat protein to get it, to get the phenylalanine to convert to tyrosine. But what's really fascinating is tyrosine is a precursor to dopamine and epinephrine. That's critical because what happens in anxiety? You have elevated levels of dopamine. The dopamine's going up, it's getting pumped up, it's constantly your fight or flight. So this is what I call a tyrosine steal. I think what's happening is the tyrosine is being bled off to be a neurotransmitter to help this patient deal with life and the anxiety going on in a fight or flight mode on a regular basis. But now the tyrosine isn't available to make thyroid hormone. So now all of a sudden you get a dip in thyroid. So that's possible. Minerals required, and this has to do with that gastric bypass patient, starvation, iodine, selenium, zinc, and molybdenum. So if people aren't eating well or eating their vegetables or taking a multivitamin or something to replace these things, then they're going to start to have issues with making the thyroid and converting the T4 into T3.
How do we get that last one?
Molybdenum? That's a trace mineral. That where's molybdenum? I don't know. I tell people get it from the sprouts. 150 micrograms a day is critical. Or most multivitamins have it. I don't know which vegetables or probably nuts have it.
Oh, I eat lots of
Oh, yeah.
So-
And selenium's was Brazil nuts.
Selenium's Brazil nuts, right?
And you only need one a day.
Right.
Right.
Okay, so here we go. So tyrosine again. Tyrosine goes to T4, or dopamine. People stressed out and anxious, they're going to be making a lot of dopamine. This is going to be favoring this pathway. Going here, tyrosine, they either go to active hormone or go down here to reverse, the fake hormone. I call it fake when I'm talking to the patients, so they can understand the reverse T3.
I got a question.
Go ahead.
So did you get the impression, studying this, that the reverse T3 is like a biofeedback? You know how there's always biofeedback?
So that's an interesting thought. So yeah, so basically, if you think about it, if patients go into starvation or they're severely ill, the body's going to do some type of preservation maneuver. And what's that preservation maneuver? Slow down the metabolism so it doesn't waste itself. One of them is to convert more into reverse T3 because it's inactive, so you're going to completely slow the metabolism down. So it's a biological activity that's been that's an aberration in these cases.
So it's like when you're stressed out, you're kind of mimicking a starvation of sorts.
So
Because you're wasting a lot of your amino acids on stress.
if they're not eating well or if they're burning up those calories, then that's a possibility, definitely. Yeah, or they're eating, people are eating carbs because carbs feel good to eat when you're stressed. They don't have protein.
Ah.
Okay?
So, sorry to
Go ahead.
keep interrupting, but I'm wondering if during like an ICU stay, if there is an increase in the thyroid activity in certain tissues, for instance, and if the reverse T3 is acting on like other tissues. You know what I mean? I'm wondering if there's...
Yeah,
Did
so
you see that?
I have a comment, there's a slide in there. I mean, thyroid function is really complicated because those conversions you're talking about, there's a lot involved. There's transport hormones, transport proteins that bring the thyroid into the cells. And then within the cells, there are conversion proteins that convert T4 into T3 into T2. And very complicated. There can be mishaps in any one of those areas. And some cells may be functioning well and others may not. But overall, in euthyroid 6 syndrome, you're seeing a complete depletion. So, but there is a variation throughout in the metabolism and of the thyroid throughout the body. Okay, so this is approximately, so this is how much thyroid is made during the day. About 100 micrograms of thyroid hormones are secreted from the thyroid gland each day. This is in a normal person. Mostly in the form of T4 with about 10% as T3. 80% of the T4 undergoes peripheral conversion in the liver and kidney. So you got to have a functioning liver and kidney. The T3 is 10 times more active than T4, and the reverse T3 has little or no biological activity. Okay? So that's why the T3, that's the active hormone. All right, so let's look at free T3. So free T3 is the active hormone. It's short-acting. It gets in the body quickly, and it's used up in a short time. So I think it's used up in about 8 hours. And the T4 takes time to be converted. So that takes time it starts to get converted, and slowly over 24 hours it's converted. So I consider that more of a storage hormone. So the T3 is the hormone that's produced when T4 is converted into T3. Now, some patients are not converting the T4 into T3 well, and that's where you get these high T4s and critically low T3s. So ranges, I like to see them above 3.0 on a free T3 level. And, okay, so this is here. Abnormally low levels of T3 may indicate starvation. It could also indicate a long-term illness, since T3 levels decrease when you're sick. If you're sick enough to be hospitalized, your T3 levels are likely to be low. Okay? So that's, again, I think we're missing euthyroid 6 syndrome in the general population. Okay. Let me see. This goes to what you're saying, Beth. The thyroid hormone regulates a number of genes. It's a very complicated. The pathway is complex. There's a lot going on that we don't know about. We just get little snapshots of it. So this slide was just to say things are complicated. Okay. Okay, so free T4 is storage hormone. Long-lasting, comes from tyrosine, and the range is about above 1.1. All right.
Do you have any suggestions on having the phenylalanine go to tyrosine, or not to go to tyrosine, but then to go to T4 rather than to dopamine? I mean,
Yeah, to preferentially drive that pathway. Well, I think, okay, so phenylalanine is needed. When you have phenylalanine, you have to have methylation, because phenylalanine becomes tyrosine through the biopterin pathway, which is completely dependent on methylation. So that's critical. Secondly, to drive the tyrosine to thyroid, I suppose if you have an abundance of the nutrients that are needed to drive that pathway, like selenium, zinc, and iodine, maybe that will help to drive it further into that. But
I'm just thinking, like, if there's something that either...
I don't know. I think what happens is the neurotransmitter pathways are so overwhelmingly powerful that I'm not sure they can.
And I wonder how, like, some of the antidepressants and anti-anxiety medications that we use impact that as well.
Yes, so a lot of them work on the dopamine pathways.
Yeah.
So
so I wonder,
Yeah.
I don't know if that influences it, but it's always, I look for it because people who are on antidepressants and anti-anxiety medications
Tend to have it, yes. That could be because they're chronically ill.
yeah.
And they're on those medicines for that reason. So, okay, now I showed you patients 1, 2, 3, and now I'm going to show you patient number 4. And, okay, these patients were poor converters. They had enough T4, but they were not converting to T3. All right. Now this last patient, number 4, not the last, but this patient is on Synthroid. She has fatigue, anxiety, and agitation. She's interesting. So, 92 years old. Her family brings her in. They said, Mom's getting agitated. We removed her to a board and care, and she's just not herself. She's not clear in her head. She's not demented. She's just kind of agitated for some reason. She's got the nerves are going. She's got anxiety. She's tired. She feels more tired than normal, and she's able to describe this to me. She's not demented. So I said, okay, let's get some basic blood work and kind of figure out where you're at. So this is her blood work. She's on Synthroid. So her free T3 is 1.39, and her TSH is 3.28. You'd say, wow, that looks good. But then you go to her T3, it's 1.9. That's even below the lab standard, the lab range. And her reverse T3 is 16. Should be 10 to 12, but on a 1.9 free T3, that's a high reverse T3. So again, this woman over time with chronic illness has now decreased her free T3 production and increased the reverse T3, and she doesn't feel well. So what happened with her was we gave her some thyroid, we gave her some different nutrients that she was lacking on the blood work, and she moved into a board and care, and I hadn't seen them for about 3 months or 4 months, and all of a sudden she pops back into my office. Like, Mom's agitated again, she's not doing well, and she's sitting there kind of nervous on the chair, like, what happened? Well, she was doing great. And I started going through, well, okay, she's on board and care, what are they doing? They dropped the ball on all the nutrients. They were giving her the wrong thyroid, a fraction of the dose she was supposed to be on, and she just slipped right back into where she was. So this was about 3 weeks ago, and now we've got her back on everything, and we'll be following up to see if she can recover. But that she was doing great. She had converted and was feeling much better. Okay, so thyroid. This is reverse T3. Again, I call this the fake hormone. When I'm talking to patients, I want to tell them, like, this is the active one, does the job, and this is the fake one that doesn't really work. It's an isomer with little or no biological activity. It blocks the effects of T3. It's produced in patients who have stress. So you get a higher T3 in patients that have stress or chronic illnesses like diabetes or heart disease, depression, things like that. Present in chronic illnesses, diabetes, CAD, chronic fatigue, chronic infection, Lyme disease type things, chronic psychological issues. So we like that to be in a range of about 10 to 12 or less. Okay, thyroid and TSH. This is interesting because why are all these patients not having normal TSHs yet they feel bad? Remember, it's a clinical diagnosis, and their numbers are showing that they're low. Well, what this talks about is the idea that the pituitary is more sensitive to thyroid hormone. It has either more transport hormones, or the transport hormones have a higher affinity for the thyroid hormone, so they will grab thyroid hormone as it's passing by, bring it in the cells, and they're happy. So the pituitary says, I've got plenty of thyroid, I don't really need to do anything, we don't need to produce any TSH, but that it happens to be at a lower level than what the rest of the body may need, and the rest of the body suffers, and that's where patients come in saying, I don't feel well. So this is where for these individuals and for patients with central hypothyroidism where the TSH is not a reliable indicator, better tissue markers of thyroid hormone action are required to help guide replacement strategies such as like the T3 and the T4. Okay, again, complexity of pathways here. But that's an interesting concept. Like, why are these patients having normal TSHs but their other numbers are off and they don't feel well. Okay, other thyroid hormones. This is an interesting thing. I had never heard of motilin until about 2 years ago at a conference I was at. Well, what is motilin? Motilin is a general term for hormones that cause motility in the intestinal tract, okay? And thyroid makes thyroid motilin. Well, that's interesting. Thyroid patients that have problems have got constipation. Well, that's what's happening. Their thyroid is not functioning in multiple different ways. And so in our studies show that both the concentration of plasma motilin and gastric motility were decreased after thyroidectomy. All right. So keep that in mind when we go down and talk about the hormone replacement. Okay, what constitutes a normal thyroid level? Okay, when you get your lab values, labs, they give you a range. They don't give you normals. They take the lab work, the blood work that comes into the lab, they take 2.5% off the bottom and 2.5% off the top, and those are the ranges they give you. Well, what kind of blood work goes to labs? Sick people, not normal. And these ranges are wide because some normals go and some don't. But the issue is that when you say that this person's lab work is abnormal because it's below 2.0, that's below their lab range. I think that lab values are abnormal when they're not in an optimal range. So what is optimal? What would you look at to be optimal? Like, we want hormones to be at an optimal level that is productive and helps the body to metabolize properly. Well, let's look at some young adults, young, healthy adults, and see what kind of numbers they have. All right? So this is a 14-year-old, great health, and feels good, has no complaints, came in for a general wellness exam and wanted some blood work. Her free T3 is 4.6. Okay? And now the next one. This is a 17-year-old. Little stressed. She's in high school. She's trying to get to college. She's working hard. Maybe had a little bit of fatigue, but generally felt well. She's able to get through the days and really power through things. Very intelligent girl. And her free T3 was 3.4. So that to me kind of indicates these are healthy young people. These are levels that are optimal, right? Okay, so severe illness versus chronic illness. There's an article that talks about the decreased circulating concentrations of T3 in the severely ill may be due to reduction of this activity. That's the deiodinase. That's the converting enzyme from T4 into T3 as a result of low calorie intake, again starvation, and raised glucocorticoid response secretions in response to stress. What happens in stress? Everybody, the cortisol goes through the roof. People get stressed. Their immune system goes down, they get sick. So, again, this is a chronic illness versus a severe illness. This reduces the conversion of T4 into T3 and concomitantly the T3 to T2. So, again, these people that have fine T3s but they're not good converters, fine T4s, but they're not good converters. And remember, T3 is the active hormone. You've got to have T3. So treatment. So these patients need T3 and T4 because they're not converting the T4, which is synthroid. Levothyroxine is strictly T4. So they need T3 and T4 because what happens is when you give them the T3, you break that cycle of conversion of T4 into reverse T3 because they don't need to convert so much. And therefore, you can help to start to lower the reverse T3 levels. So there's a couple ways of doing it. You can use the desiccated pig thyroid. Generally, doses are 1 to 2 grains. That's been around for 100 years. You can use levothyroxine, T4, and you can use liothyronine, T3. Those are both prescriptions, pharmaceutical companies making those. The reason for the T3 and the T4 is to address the low T3 and also get the production of reverse T3 down to a normal level. T4 alone may not bring the T3 to normal. So this is what I see sometimes. Patients are put on the T4 only. They're like, I'm on the T4, my numbers look normal, but I don't feel well. And they're not converting. Or they're making too much reverse T3. Like a couple of those patients that had high T4s and the reverse T3s were 26. So, okay, you can use the T3 and T4 prescription. This is prescription nature thyroid, pig thyroid. But what's really fascinating about the porcine thyroid is it's the whole thyroid. It's desiccated pig thyroid. So it's got selenium in it, it's got zinc, it's got iodine, and it's got thyroid motilin in it. So these people that are having bowel issues, you give them that, all of a sudden things start going better. All right, side effects, not much. They generally definitely feel better. They'll tell you, my hair's falling out all the time. My hair's falling out. But what happens is when patients are in a low thyroid chronic illness state, their hair stops cycling. It stays in like the phase before fallout. Then what happens is you start getting them to eat well, they're eating protein, they're eating fats, and you start their thyroid humming, and all of a sudden the hair starts cycling again, but there's a lot of hair that's in the fallout phase, and they say, I'm falling out, I'm going to go bald in 5 months. But that's not really what's going to happen. The hair will start to regenerate again because everything's been turned back on. All right? Now, sometimes they may not feel better. You know, sometimes there's other things going on. You may need to modify the doses. It doesn't happen very often, but it's a possibility. Any questions or anybody? All right. So follow-up testing. So I like to do about 5 weeks after starting the thyroid, I'll check a free T3, free T4, reverse T3, and TSH. I kind of came up with the mid-range of the laboratory ranges is about 3.0. So if we can get it above 3.0, then I think that's a good level to be at. The patients, they feel better at that level, so it's kind of a good sign that that's a good spot. TSH is tricky because sometimes that T3 will drive it down because remember, the pituitary may be more sensitive to the TSH. The other thing that you should do is when the patients get their thyroid functions that morning, don't have them take that thyroid medicine because the T3 gets in quickly and you'll get these high T3 levels of like 5.4 because it's rapidly absorbed and it's rapidly used up in about 8 hours, but if you measure their level at about 8 or 9 or 11 in the morning, it'll be high. So you need to ask them not to take that medicine in the morning, and if they do take it, then just remember that and take it into account when you go through the blood work with them. So follow-up patients. This is the gastric bypass patient. So she had, we put her on some thyroid, probably maybe 1 or 1.5 grains, and her TSH was 0.88. The free T3 went up to 3.1. So she's feeling much better. That's over in this area. So that was she was happy. And another patient, this is a number 7 patient. So this lady, she came in, usual picture, fatigued, not feeling well, wanted to get taken care of. Her original numbers were, the TSH was 1.76, her free T4 was 1.13, and the reverse T3, the free T3 was 2.5. Again, below that 3.0 threshold. Her reverse T3 was 17. We want that to be 10 to 12 or less. So it's okay, you got thyroid problem amongst whatever else you treated her with. Gave her some thyroid, probably about 1 grain. And the results over here are, her TSH went to 4.49, T4 actually dipped a little bit at 0.87, but the free T3 went up to 3.2. Okay, and what also was good was that the reverse T3 went to 12, so it came back down into a more normal range, and she felt better. All right. So summary. Euthyroid 6 syndrome, subclinical hypothyroidism. I don't think it just applies to the critical care patients. I think this is rampant in our population, and it's something that we need to recognize. It's due to chronic illnesses, which are endemic. You got fatigue, insomnia, anxiety, depression, high glucocorticoid levels, chronic infections. these chronic illnesses and they upset the thyroid balance. Okay, other considerations, don't treat thyroid in a vacuum. Always look at the other hormone systems like the testosterone, estradiol, progesterone, and adrenal hormones. The other thing that's very interesting is when you give someone thyroid, it starts to turn on the cells. It starts the mitochondria producing energy. But if the mitochondria don't have the cofactors to make energy, then you got a problem. And the patients will feel better for several weeks, and then they're like, I'm back to where I was. What happened? That's because they're not nourished. So you got to give them CoQ10. You got to give them mitochondrial support. CoQ10 is huge. A good multivitamin. Vitamin C is important. Methylation support. All these things are needed to treat the holistic patient. All right? So if you just give thyroid and turn the system on without the holistic consideration above, the patient will feel fine for a short time and then revert back. It's like whipping a tired donkey to go uphill, like, come on, come on. The thing's looking at you saying, feed me and I'll go. So that's how the mitochondria are when you give them thyroid stimulation. And that's it. Any questions?
Sorry.